Good morning, everyone. Welcome to Wednesday morning cardiology rounds. It's my pleasure this morning to introduce one of our second-year electrophysiology fellows, Dr. Ghalib Al Hinai. He did his internal medicine training in the UK and his cardiology training at McGill, and he spent the last couple years with us in our electrophysiology team. So he's going to speak with us today about updates from HRS. So welcome, and we look forward to your presentation this morning.
Thank you very much, Dr. Stadnik. So yeah, I was asked to give a talk this morning, and I thought since we had the Heart Rhythm Society Congress just a couple of weeks ago, it would be a good opportunity to go through some of the late-breaking trials there and talk about what's new. So there were several interesting trials that were presented at the meeting, but I thought I'd speak about these three. So the first one is the ATLAS trial, which is avoid transvenous leads in appropriate subjects. The second one is the AWARE trial, augmented wide area circumferential catheter ablation for reduction of AFib recurrence. And then lastly, the left bundle branch pacing resync trial. And what this looked at was left bundle branch pacing versus bi-V pacing for cardiac resynchronization therapy. So we'll start off with the ATLAS trial. Transvenous ICDs, we know that they're effective. Landmark trials showed 20 to 30% relative reduction in mortality with transvenous ICDs. But you know, unfortunately, as with many interventional things in medicine, they're not without their complications. And transvenous leads remain the weakest link in the transvenous system, with most of the morbidities and most of ICD-related morbidity being related to lead complications. So to just put that into numbers for you, one study showed that 1 in 8 patients may experience complications with ICDs, with lead-related complications being up as high as 5.5%, pneumothoraces up to 2.2%. And really, I consider pneumothorax a lead-related complication because, you know, you get a pneumothorax typically from trying to obtain access, endovascular access, and of course, endovascular access is needed to implant the endovascular lead. So really, if you add up the first two, up to 7.7% of ICD-related complications may be secondary to the leads. So the thought was to try and develop a non-vascular system as an alternative. It was first introduced in 2009, and the hope was that subcutaneous ICDs would overcome lead-related complications. So this is just a visual representation of it. If you look here, this is the can. It sits in the axillary area, usually subcutaneous or sometimes submuscular. And then the lead is tunneled under the skin up to the left parasternal area and sits like that. And on X-ray, it should look something like this. So you have your lead sat there, the parasternal area, and then you have the can on the side. So what are the pros and cons? Obviously, the pros, one of the main pros is that it's an extravascular lead, so you're avoiding transvenous lead-associated complications. The other thing is that it serves as an effective shock box. Of course, the main con is that because this is a subcutaneous rather than an endovascular lead, it does not have a pacing function. So you can't deliver any pacing with subcutaneous ICDs, and therefore it's not suitable for patients who have a pacing indication, such as those with bradyarrhythmias, those who need cardiac resynchronization therapy, and patients who would benefit from ATP, such as those who have known frequent monomorphic VT. And the other thing is for subcutaneous ICDs, patients need to be screened, and they need to pass the screening to make sure that they wouldn't end up getting oversensing and inappropriate shocks. Typically, T-wave oversensing is what we'd see. So this is just very briefly the screening method. So before implanting, the patient would be screened, and they look at 3 vectors. This is your primary vector from here to here, which is A. You have your secondary vector from here to here, and then you have your alternate vector. And they really need to pass one of them to be able to be deemed suitable candidates for subcutaneous ICDs. And what they do during the screening process, you have here on the left, you could see there are these templates for the QRS to fit in, and they compare the patient's intrinsic QRS to the template, and the intrinsic QRS has to fit in to the template, right? So if any part of the QRS is outside of the template, so I think this, for example, number 2 is a good example. You see the T wave here clearly outside the green template. Then that patient would fail screening because they'd end up getting oversensing and inappropriate shocks. So, when you take into consideration all the pros and cons, classically we've had ideal candidates, or what we consider niche candidates for subcutaneous ICDs, and those would be your young patients, who are typically very active and maybe more prone to mechanical complications of endovascular leads. Patients who have a high risk of infection of lead complication, those without venous access, and patients who have inherited disorders like channelopathies and arrhythmogenic cardiomyopathies. And that's because typically these patients would end up getting polymorphic VT or VF. So really, there's no role for ATP here, and all they need is a shock. So that's been sort of the classic approach. And what does the evidence say? So up to recently, all we had was registry data. And what that data showed was that subcutaneous ICDs had a high shock efficacy compared to transvenous systems with less lead complications, but a high inappropriate shock rate. And until 2020, there were actually no randomized controlled trials comparing the two therapies. And this is where the Praetorian trial came in, or stepped in to fill that gap in the literature. So I'll very briefly talk about this and what it showed. The Praetorian trial was published in the New England Journal of Medicine in 2020. And the authors, what they wanted to do here is they wanted to look at a more conventional ICD population rather than just those niche patients that I mentioned earlier. And it was a non-inferiority trial. So they wanted to show that subcutaneous ICDs are non-inferior to transvenous ICDs with respect to major ICD-related adverse events, which they defined as inappropriate shocks or ICD-related complications requiring intervention. They included, patients over the age of 18 with a class 1 or 2A indication for ICD. 849 patients were enrolled across multiple centers in the EU and United States. They were followed up for a period of 49 months. Excuse me, median period of 49 months, with the primary endpoint being a composite of device-related complications and inappropriate shocks. And this is what they found. So for the primary composite endpoint of both inappropriate shocks and lead-related and ICD-related complications, subcutaneous ICDs were non-inferior to transvenous ICDs. I think that's a good segue into the trial that was presented this year at the HRS, which is the ATLAS trial, Avoid Transvenous Leads in Appropriate Subjects. This is a Canadian trial out of Hamilton. It's a multi-center trial, and our department was involved in it, with the site investigators being Dr. Burney and Dr. Sadiq. So what the authors here wanted to show, this was actually now they wanted to take it a step further, and this is actually a superiority trial. So they wanted to show that subcutaneous ICDs actually reduce the rate of major lead-related complications measured at 6 months following implant. That was the primary objective. And for the second objectives, they wanted to show that sub-Q ICDs had a similar risk of inappropriate shocks and a similar risk of failed appropriate ICD shocks. And then to show that subcutaneous ICDs reduce all-cause ICD-related reoperation. So really, what they were looking to show is, can we use this, and is this a good alternative? This is just an overview of the design. Patients were screened and enrolled, then they were randomized in a 1-to-1 fashion with follow-up visits at 1 month, 6 months, 12 months, 18 months, and 24 months. This was the inclusion criteria. So like its predecessor, they didn't just want to include those ideal candidates. They wanted to look at a broader, more conventional ICD population. So they looked at both patients, between the age of 18 and 60 with a standard indication for ICD, and patients over 18 who would have an inherited arrhythmia syndrome, and patients maybe like those who needed hemodialysis, where venous access would be challenging or not appropriate. Exclusion criteria. So these were the main exclusion criteria. Put simply, patients who either needed brady pacing or patients who did not have endovascular access were excluded from the trial. And the primary outcome they defined was a composite of major perioperative lead-related complications measured at 6 months, including hemothorax or pneumothorax, cardiac perforation, tamponade, effusion, pericarditis, lead dislodgement or loss of pacing and sensing, new moderate to severe TR or severe TR, and ipsilateral upper extremity DVT. So that's sort of typical complications we see with devices. And then they actually set a secondary 6-month safety composite, which included the above plus device-related infection, pocket hematoma, MI, stroke, or death. And this is the study design. So you can see they enrolled a total of 544 patients. 41 had failed the screening, which we talked about earlier, leaving us with 503 patients who are randomized in a 1-to-1 fashion, with 251 in the subcutaneous ICD arm, 252 in the transvenous ICD arm, and they were then followed up. And you could see here in terms of crossover, you had about 9 patients from the subQ ICD arm who crossed over to the transvenous arm, and a total of 5 patients who crossed over from the transvenous into the subcutaneous arm. So not a very large number of, not a very large crossover number. And the mean follow-up was 2.5 years. Very briefly, baseline characteristics. You could see here, average age was about 50 years old. Males made up almost 3/4 of the population. Just quickly looking through that, you could see that the patients were fairly matched across across both arms. And this was the baseline cardiac conditions. So just over 1/3 of patients were your ischemic cardiomyopathy patients, and just under 1/4 were the dilated cardiomyopathy patients. And between these two groups, they made up about 50% of the patients in each arm, with the remaining 50% spread out across the conditions listed here. And again, it's just to show that the two arms were fairly well matched as well in terms of baseline cardiac conditions. So what did this trial show? So it showed that the subQ for the primary, as a reminder, the primary outcome was a composite of major lead-related complications at 6 months, and it showed that subcutaneous ICDs had less or performed better than transvenous ICDs in regards to that primary outcome, with the difference reaching statistical significance. And you could see there, like almost no lead-related complications in the subcutaneous ICD arm compared with the transvenous ICD arm. For the secondary safety outcome, no statistically significant difference across the two arms. And then inappropriate shocks. So again, no statistically significant difference between the two arms. Numerically, the subcutaneous ICD had slightly more inappropriate shocks, and the majority of those were caused by T-wave oversensing, which is reflective of what we see in practice. Usually the ones who do get inappropriate shocks are because of T-wave oversensing. And it's just worth noting that newer devices do have algorithms to try and overcome that. And again, in terms of ICD effectiveness, which was defined as a failed first shock, no statistically significant difference between the two arms. And here, this Kaplan-Meier curve just shows the all-cause reoperation for ICDs or lead-related issues. And you could see there at 6 months, the two curves are almost overlapped. And again, no statistically significant difference between the two arms. So I think the conclusions are that from this trial, at least, is that subcutaneous ICDs, had almost no lead-related complications, and there was, in regards to the secondary outcomes, there was no significant reduction in ICD performance with the subcutaneous ICDs, and that was defined as both inappropriate shocks and unsuccessful first appropriate shock. And of course, one limitation to both these trials is that the follow-up period wasn't very long. So additional longer-term data, should give additional precision. And that subcutaneous, and really I think subcutaneous ICDs can be considered as an alternative to transvenous ICDs. And important to say, it's important just to highlight that we're not saying that it's a substitute to transvenous ICDs, but it can be an alternative, particularly when prevention of lead-related complications is desired. I think that's a take-home message from this trial and its predecessor, the Praetorian trial. So that brings us to the end of the first trial. The second trial that I'd like to present is the AWARE trial, which is augmented wide area circumferential catheter ablation for reduction of atrial fibrillation recurrence. This is a randomized clinical trial. Again, this is a Canadian trial. This one was actually out of Ottawa, the Heart Institute, with the designated principal investigator being Dr. Nair. And essentially, a bit of background. So several trials have looked at the success rate of catheter ablation for paroxysmal atrial fibrillation. You could see there with 1-year success rates ranging between 57 to almost 75%. Two things that are important to note when looking at this data. Firstly, the intervention used differed across the trials. So some used cryoablation, some used radiofrequency ablation, some used contact force guided PVI, adenosine guided PVI. And the second point to note is the monitoring strategy. It wasn't homogeneous across all studies. So some used 24-hour halters, some used implantable loop recorders as well. The meta-analysis that was done by Dr. Neri back in 2016 showed that the main mechanism for AFib recurrence post-ablation is pulmonary vein reconnection. So there was studies that looked at different techniques used to do PVI and what would essentially achieve durable pulmonary vein isolation to try and help reduce chances of reconnection. And two methods that were shown to be effective was adenosine testing and contact force during the procedure. And really that's what the authors wanted to look at with this trial. They wanted to see how could we achieve durable pulmonary vein isolation to try and avoid or reduce the risk of reconnection and recurrence of atrial fibrillation. So just briefly, I thought it might be worth mentioning how we achieve pulmonary vein isolation during ablation. The way we do it is by doing a WACA. And what that is ablation lesions are delivered in a circumferential fashion on the antrum of each pair of pulmonary veins. And I'll show you a picture of this in a minute. And WACA essentially stands for wide area circumferential ablation. Okay. So what the authors looked at is they wanted to see if doing a double WACA, or the hypothesis was that double WACA will increase the success rate of ablation by achieving durable PVI, additional substrate modification, and modifying extrapulmonary triggers. It was a multi-center prospective randomized blinded endpoint design. Sample size was 396, and these patients were randomized in a 1-to-1 fashion stratified by site to either the control arm, and these were patients who received a single WACA with adenosine testing, that was considered the standard of care, or the experimental arm where they received a double WACA without adenosine testing. And randomization was conducted after completion of the first WACA procedure to reduce bias. And what that means is that the patient, a patient who's having an ablation, he or she would have the first WACA done, and then there'd be an envelope in the control room in the lab. They'd open it after the first WACA is done, and then that would say whether the patient was in the experimental arm or the control arm. So it was actually quite a good way to try and reduce operator bias. And here, this is just a picture illustrating that. So on the left, this is our voltage map, and on the right here, you have the 3D anatomical map. And these dots here are the ablation lesions, and this is the WACA. So you could see it's a ablation lesions delivered in a circumferential fashion around the antrum of each pair of pulmonary veins. So in this case, this is the right upper and right lower pulmonary veins, and you could see the WACA there delivered around them. So a double WACA is essentially just another line, just proximal to the first one. That's what the double WACA was. And you could see that here again. This is the sort of anterior view. This is the posterior view. And you could see there two lines. And this is just some technical information about some technical details about the ablation. And it's just to show that ablation was standardized in the study to try and avoid operator bias. So the inclusion criteria: patients over the age of 18 years old, patients who had symptomatic paroxysmal atrial fibrillation who either did not want to take antiarrhythmics or were intolerant to antiarrhythmics or were refractory to at least one class 1 or class 3 antiarrhythmic. And the standard exclusion criteria was used that's typically sort of seen in paroxysmal AFib catheter ablation RCTs. The primary outcome was atrial tachyarrhythmia recurrence between 91 and 365 days post-catheter ablation. And that was defined as atrial tachyarrhythmias were defined as atrial fibrillation, atrial flutter, and atrial tachycardia. The monitoring strategy used was 14-day halters done at 3 months, 6 months, and 12 months post-ablation, in addition to any ECGs that were done during clinical visits, emergency room visits, or any incidental ECGs that were found. So if you add up all those halters, you end up with 42 days of continuous ambulatory monitoring. Here you could see a total of 398 patients were randomized, 195 in the single WACA arm, 203 in the double WACA arm, and all patients were seen to follow up. Baseline characteristics, again, fairly well matched across both arms. Average age was about 60 years old. Females represented about a third of the cohort in each arm. And average CHA2DS2-VASc score was 1.5. And the left atria were mildly to moderately dilated by index volume. And that was similar again across both arms. So what did the trial show? So the trial showed that there was no significant difference in primary outcome between the single WACA arm and the double WACA arm. And again, based on known predefined subgroups, analyses did not show any significant difference between the groups in the two arms. Secondary outcomes, so this was defined as repeat catheter ablation between 91 and the need for repeat catheter ablation between 91 and 365 days, or hospital or ED visits for atrial arrhythmias after 90 days post-ablation, and again, no statistically significant difference across the two arms. And then importantly, for safety outcomes, again, no significant difference across the two arms in regards to serious adverse events. No deaths, strokes, or ACS was documented, and very importantly, no cases of atrioesophageal fistula across both arms. I think in conclusion, this was a multi-center randomized clinical trial evaluating the efficacy of an augmented ablation strategy in improving arrhythmia-free survival in patients with paroxysmal atrial fibrillation. A double WACA was not superior to a single WACA with adenosine testing. There was a high single procedure success rate reaching approximately 75%, and freedom from the need for repeat catheter ablation reaching approximately 90%. So this was suggestive of a possible seeding effect to PVI in patients with paroxysmal AFib. And also importantly, ablation techniques, or the different ablation techniques, did not affect safety profile of the procedure. In terms of future direction, so the next question is, would doing a single WACA versus doing a WACA and targeting non-pulmonary vein target sites, such as low voltage areas, would that help improve durability of the ablation of the procedure? This is unknown. It's something that's going to be studied in a trial called AWARE-2, which will be done again here out of Ottawa, and will be a multi-center trial. So watch this space. Okay. And the last trial I'd like to present is left bundle branch pacing versus biventricular pacing for cardiac resynchronization therapy. So this was a randomized controlled pilot trial. It was a Chinese study out of China, and it was the first randomized trial to look at left bundle branch pacing versus biventricular pacing. So conduction system pacing, the last decade has seen an increasing interest in conduction system pacing in the EP community and in the wider cardiology community. HIS bundle pacing classically is seen as the alternative to traditional RV pacing, but of course it comes with inherent limitations. Those being that one, the HIS area is quite small, so you end up having a small target zone, which can result in longer procedure times. The other thing is that the HIS area is it's a very fibrous and well insulated area, so you end up needing higher thresholds to actually pace. And then because, of course, the HIS is quite annular, it's an annular structure, so you end up getting issues with atrial oversensing and low R wave amplitude. And this is typically some of the issues that we've run into when we follow up patients in clinic. So left bundle branch area pacing, which was first described in 2017, has been rapidly emerging as a successful alternative, and there's also some observational data to suggest that it is successful in correcting left bundle branch block. This here is a MRI, 3D MRI reconstruction of the conductive system. So the green area here, that is your HIS area. You could see it here, and then the red is the right bundle, and the purple is the left bundle. And you could see here the red star represents the HIS area pacing, and you could see really you only have a small target zone for HIS area pacing. Now compare that to the orange stars, which represent left bundle area pacing, and you could see already that you have a lot more space where you could, or a lot more areas rather, where you could implant your lead. Okay, so again, this is the red is the HIS bundle pacing, and then the orange stars, that is your left bundle area pacing. This is a case that I did with Dr. Sadek a couple of months ago. So you could a case of left bundle area pacing. So you could see here in the AP or the PA viewer even looks similar to sort of septal RV lead placement. But when you look at the lateral view, you could just really see that the lead is quite embedded there into the septum, so that you could get across and actually capture the left bundle. And this is this patient's ECG. So remember, because we're pacing the left bundle, we're actually inducing a right bundle, which you could see quite nicely here in this ECG. And you could also straight away see that the QRS is much narrower than what we normally see with the classic RV area or RV apical pacing. So back to our trial. So this was a prospective randomized randomized controlled pilot trial. Essentially, they wanted to look at, the feasibility and safety of left bundle pacing compared to biv pacing. So they enrolled patients between the age of 18 to 80 with normal sinus rhythm, non-ischemic cardiomyopathy with an EF of less than or equal to 45%. Who had been on guideline-directed medical therapy for at least 3 months, but remained in NYHA class 2 to 4. So you're a classic, CRT candidate. They randomized them in a 1-to-1 fashion between the two groups, and the patients were followed up at 3 and 6 months. So 73 patients were screened between December 2019 to June 2021. 40 patients were randomized, 20 were male, 20 were female. In regards to crossovers, you had 2 patients from the left bundle group to cross over to the biv group, and that was mainly just because they couldn't penetrate the septum and capture the left bundle. And in the biv group, you had 4 patients to cross over to the left bundle group, two of which were because of failure to cannulate the CS. One was because of phrenic nerve stimulation, and one was because of high pacing threshold. Mean age was 63.7 years, mean left ventricular ejection fraction was 29.7%, and the mean QRS was 174 milliseconds. So what did the trial show? This is the primary outcome, which was change in LVEF from baseline to 6 months follow-up. You could see here that both arms resulted in improvement in the EF, with a further 5-point increase in the left bundle arm. And this did reach statistical significance. Secondary outcomes, so these were defined as reduction in LV end systolic volume, NT-proBNP, and QRS duration. And you could see, based on an intention to treat analysis, again, left bundle pacing performed better than BiV pacing in terms of reducing LV end systolic volume and reducing NT-proBNP levels, both of which reached statistical significance. In terms of QRS duration, there was no statistically significant difference between the two groups in an intention to treat analysis. And just a bit, one slide on procedure-related data. So thresholds were fairly similar across both arms. Lead impedance was similar between the BiV and left bundle arm. And then in terms of down here, if you look at X-ray fluoroscopy time and X-ray and procedure time, while numerically left bundle pacing was shorter than BiV pacing, there was no statistically significant difference between the two groups. And from the safety side of things, one patient in the left bundle branch pacing arm had lead dislodgement 2 days after the procedure, and one patient in the BiV group had a pneumothorax. There were no other cases or recorded cases or reported cases of lead dislodgement or pneumothoraces, and no rehospitalization or ventricular arrhythmia events during the follow-up period. So conclusions from this trial, as I stated, this was the first randomized controlled pilot study comparing the two pacing modalities. The results of this trial, along with other previous observational studies, suggest that this is a promising technique and it does have its advantages. But there are two important things to bear in mind. The first is that there's no long-term data available on the safety of left bundle pacing or lead performance over a long period. And of course, with BiV pacing, we know that we have well-established, robust, long-term data showing showing benefit in both morbidity and mortality. So I think, in summary, it's a new pacing modality. Results look promising, but really large-scale prospective randomized controlled trials are needed before we can draw any definitive conclusions. And with that, I'll end. Thank you very much for listening, and thank you for your time.